The official kickoff of winter is less than 10 days away from now. And the pandemic looks quite a bit different than it did in 2020 prior to the vaccine. But this year, we're also dealing with RSV and a very aggressive flu season. Plus, COVID continues to mutate. Good evening and welcome to Rural Health Matters. I'm Christina Loren. Joining us tonight, as always, Dr. Jeffrey Gold, the Chancellor of the University of Nebraska Medical Center. And a little bit later on tonight, we have a very special guest joining us, a very smart woman, Dr. Ann Anderson Berry, who serves as Professor of Neonatology at the University of Nebraska Medical Center. She's also the Executive Director of Child Health Research. Dr. Gold, thank you so much for joining us this evening. I know that our viewers are looking forward to your updates. There's a lot that's happened in the news cycle. People are probably going to want to ask you about tonight, but let's get right to the numbers. Where are we right now in terms of the data?
Sure. Well, thank you, Christina. It's always a pleasure to be with you and be with our audience on Monday night. And you're right, there's a lot changing. And so I think we should just get right into the data so we have plenty of time for Dr. Anderson Berry and plenty of time for our audience to call in. So we look at the map worldwide. Again, the patterns are changing subtly. They may not be that easy to discern, but certainly a tremendous amount of COVID in Western Europe, the Scandinavian countries. The deeper amber color in the United States is representative of more COVID in the U.S., in Brazil, more COVID in Argentina. But if you look at Peru and if you look at Chile, again, an intense coloration, meaning a lot of cases. Similarly, what's going on in Japan, what's going on in Australia, New Zealand, and of course, we're not really tracking what's going on in Russia, in Mongolia, in China right now because of difficulties in getting accurate case numbers, which is also true with what's going on in Africa. But for the countries where we are getting accurate case numbers, unfortunately, they're going in the wrong direction. Worldwide, we're up to about 7 cases per 100,000 per day, or just over 550,000 cases yesterday. That's a 23% change over the last 14 days. And even we're now starting to see the reversal of what had been a fairly long, persistent fall in death rates and case fatality rates. When we focus on the U.S., unfortunately, the map continues to show more and more hotspots of darker coloration, meaning higher reported COVID transmission rates. And of course, as our audience has heard me say many times, we are significantly underreporting. But if we look at what's going on in New Mexico, Arizona, Colorado, in Utah, if we look at Kansas, parts of Nebraska, unfortunately Oklahoma, the panhandle of Texas, and then you look at the Great Lakes region as well, you can see darker colors of bright red, amber, and yellow, which were not present on the maps just as recently as several weeks ago. When we look at the U.S. numbers, again, concerning, overall cases are up 56% over the last 14-day period. We've now up to 20 cases per 100,000 per day. Don't forget, worldwide, we're at 7, so this is almost 3 times the global level. We're up to about 65,000 confirmed cases yesterday, and don't forget, yesterday was a Sunday weekend. Hospitalization up 28% over the last 14 days to 12 per 100,000 per day, just over 38,000. And indeed, we've seen an uptick of approximately 40% over the last 14 days in case fatality rates in the United States. Our audience will recall it was just several weeks ago we were hovering at about 225 to 250 patients losing their life to COVID. And now we're almost twice that. We're up 40% just in a 2-week period. If you look at the run chart from the beginning of the pandemic until recently, you can see that the case numbers appear to be going up and certainly by no means have peaked. And so, as you pointed out very accurately, a year ago, Christina, we were dealing with the very early parts of the Omicron spike that was so devastating in January and February. Unclear whether we're going to see that type of spike or a much more muted spike as a direct result of the Thanksgiving holiday and all of the travel. If we look at cases by state, you can see New York, Arizona, New Mexico, California, New Jersey, anywhere near from 1.5 to a little more than that times the U.S. average. And so the whole country is actually seeing some increase, but mostly in the states listed here. At least that's where the testing has revealed it. But in some of our smaller counties, whether it's in Tennessee, California, Kansas, Arizona, or Oklahoma, widely, we're anywhere from 6 to 4 times the U.S. average. Now, again, the case numbers are small, but again, making the point that rural America is by no means immune, even though there's been so much case transmission, so much infection, and the use of our vaccines. Hopefully, these folks are staying out of the hospital and just getting tested and recovering. If we look at our wastewater numbers, again, 62% of the 1,280 sampling sites, that is approximately 2/3 of all the sampling, is now in the highest category in the United States. So I draw your attention to the Great Lakes region, to the central Midwest, to the far west, to the mid-Atlantic, the Northeast. There are very few parts of the country that are not seeing, in the areas being sampled, a bright red or an amber coloration, indicating the highest possible wastewater levels. And of course, as our audience knows, those wastewater numbers are very predictive of what we're going to see in 2 to 4 weeks. And as a matter of fact, if you look at the last month or so, the last 5 weeks in overall wastewater viral particle counts, you see we're up 68%, or more than 2/3 in the last 5 weeks. And so again, just wait a couple of weeks and we're going to see that in our case numbers. Hopefully not in our hospitalizations or case fatality rates, but there's no way to predict that based upon vaccine use, overall immunity, and other factors. Another consideration is the U.S. COVID variants that we're seeing. It was just a couple months ago that we're 95% of the BA.5 subtype. But the BA.5 subtype has come well down to just over 11%, and we're just under 70%, 68% is either the BQ1 or the BQ1.1 variant. And you can see the distribution here of some of the others, including the XBB, which is now at 4.5%, which is one we monitor very closely because the transmission rates in Europe for the XBB, also sometimes known as the super spreading variant of Omicron, is quite concerning, as we see that here in these numbers. Broken down by different parts of the U.S., you can see BA.5 has become extremely small and sliver, and again, it's the BQ subtypes seen in forest green and dark green here in almost every part of the country, as reflected in the case rates. This is a chart that we've shared previously with the audience. It looks at the rate of mutation of the SARS-CoV-2 virus going back to December of 2019, so almost exactly 3 years ago. And you can see that these mutations occurred almost in a linear fashion for the first 2.5 to 3 years, and over the last, I would say, 6 months, as you see here in the yellow, amber, and orange dots, the rates of mutation have really started to increase. And so for reasons we don't quite understand, whether it's changes in the virus itself, in the genetic material, or whether it's changes in the environment, whether it's due to zoonotic spread to animals and then reverse transmission to human beings, all of that is unclear. But what is clear is that the rate of mutational change of the virus is increasing at a faster rate. And that's of concern. If we look at hospitalization and ICU care in the U.S., as I said a few minutes ago, hospitalization is up following the Thanksgiving holidays, and we haven't seen a peak of it just yet.
It appears we may have lost Dr. Gould's audio.
We look at the numbers statewide. You can see that Washington, D.C., Delaware, New York, Missouri, Arizona are at or above the U.S. average. We look at deaths per day, as we said a few minutes ago. You can start to see that uptick in the post-Thanksgiving travel period, up to about 450 deaths in the United States over the last 24-hour period. Again, about a 40% increase of that slow but definite decline we've seen over the last several months. If we look at the deaths by state, again, there's a good deal of variability, anywhere from about 1.5 to approximately 3 times, almost 4 times in Maine, Michigan, New York. Fortunately, small numbers due to the population, but nonetheless a concerning trend. Just a little bit about influenza. This is a look at influenza hospitalizations. And you see in the far left of my screen and yours, the red line, that's this year, 2022. And you see the last 5 or 6 years in other colors. So what you already see is that we have a fairly high number of influenza hospitalizations across the U.S., but starting much, much earlier. And given the nature of the flu that we're seeing, it's concerning as to where that's going to peak and when it's going to peak. Hopefully it won't get too much higher and won't peak at a level higher than previous years. However, given the upcoming holiday season, the colder weather, etc., a basis of concern. I'll look at all of our pneumonia, influenza, and COVID mortality rates. Again, the red line, which we look at every week, you can see continues to rise after it had settled out in September. Unfortunately, that does not predict that the next several weeks are going to be at all favorable. And indeed, it just means that there'll be more empty seats at the holiday tables that would have been occupied by our loved ones. A couple of words about vaccination. Again, this is the same numbers we've looked at week after week after week. 34% of the American population are boosted. But what I have for you here is the rate of vaccination. And as you see, there is a little bit of an uptick, mostly due to the use of the bivalent vaccines. But when we look at it by age, and this was a recent publication that I thought I would share with you, if you look at the use of the bivalent booster, about 32% of those 65 years of age and older have received the bivalent booster. Less than half, 15%, in the 50 to 64-year age group. But when you get down to the teenage years, the 12 to 17, less than 5% have had the bivalent booster. And when you get down to our school-age kiddos, our 5 to 11-year-olds, you're talking about 2.2%. So again, there's a tremendous amount of variability in the use of boosters and primary series of vaccines, and much, much less than in other parts of the world. You know, this graphic was produced recently by a report in the American College of Cardiology, and it was in direct response, I found it and I share it with you, in direct response to a question asked by one of our viewers, Christina, about myocarditis following the vaccines. So in this particular study, they followed 9 million doses of the Pfizer vaccine, the BNT vaccine, that was received by 4 million people. And of those 4 million people, and again, want to repeat, 4 million people, there were 104 cases of myocarditis that were associated possibly with the vaccine. Possibly. That's 104 out of 4 million cases. And of those 104 people, there was 1 death. Now, they matched that up to a group of patients who had myocarditis, not from a vaccine dose of any type, but from a viral infection. As the audience knows, I hope that that COVID, the flu, many other viral infections, the Coxsackie viruses, etc., are not uncommonly associated with myocarditis, an inflammation of the heart. And unlike the one death out of the 104 vaccine group, there were 84 deaths in this other group, or 11 times the fatality rate. So again, just to repeat for our audience, 104 cases in myocarditis out of 9 million doses of the vaccine, 4 million people, a 1% death rate of that 104. So that's 1% of 104 of 4 million people. Or put differently, one person died out of 9 million doses of the vaccine. Again, very, very, very favorable compared to the impact of actually getting the SARS-CoV-2 infection. A few words about monkeypox. Very flat numbers, about 80,000 worldwide. In the U.S., we've yet to completely extinguish it, but we're getting very close to the baseline where we started last May when we started widely testing in the United States. The vaccines and the uptake in high-risk populations seems to be quite effective. Hopefully, we're not underreporting. But what I wanted to share with our audience tonight was some recent work that I have become aware of, known as the One Pill Can Kill campaign. And I'll tell you what that means in just a minute. But this is a look at the last years since approximately the year 2000 of the number of drug overdose cases in the United States in thousands. And in the two red bars on the right, you're seeing 2020 and 2021 numbers. Obviously, it's a little too early to get the 2022 numbers, but we're running at about 100,000 deaths, drug overdose deaths in the United States right now. And the 2 years of the pandemic have been absolutely merciless in that regard. Now, this is a look at the different types of drugs. So over on the very bottom, you're seeing cocaine. In the middle, you're seeing heroin in the light blue. But in the dark blue on the top, and this is drug overdose deaths in the United States going over that same time period, what you can see is the well over half and the fastest growing group are in the synthetic opioid group. And that would be drugs such as fentanyl. And that's a really big concern because a lot of the materials, a lot of the drugs in the United States now are being laced with synthetic opioids, which are far more potent than any of the other drugs we've seen before. This is a look over the last several years. The most recent data we have here is several years ago, but it looks at the rate of fentanyl deaths by age. And what you can see here is the fastest growing age groups are the 15 to 24 and the 25 to 34 year age groups. The largest of those are the 25 to 34-year-old age groups. Of course, there are some deaths in the older population as well, but fentanyl is an amazingly powerful drug. It's a very powerful anesthetic and a very powerful pain reliever when used under the right circumstances. But when used in this way of non-prescription means and not in a medically supervised way, it can be very, very rapidly fatal. This is a look at some of those deaths by gender, and you can see in the blue line on the bottom, you see women, and on the top line, you see men. And so while until about 2013 through 2014, the men and women were almost exactly identical, that has changed radically. And then finally, the last slide that I wanted to share with you is where this one pill can kill idea came from. On the top, you see authentic oxycodone tablets, known as the M30 tablets. On the bottom, you see the fake oxycodone tablets that contain fentanyl. Unfortunately, one pill can kill, and it's almost impossible to tell these tablets apart. And so as we get more and more evidence of use of these drugs, as more and more of these tablets become widely available, we need to do something to make more people aware. And hopefully these graphics will be useful. Please share them with your friends. Please share them with your family members. Again, if you just go to the One Kill Can't Kill website, you can get a really good idea of what's going on. So, Christina, I think we should stop at this time and use this as an opportunity to introduce Dr. Anderson Berry and, of course, to take our audience questions.
Absolutely. We have a lot to cover tonight. And as all of us in rural America know, the opioid crisis has been in rural America for years now. In fact, in 2017, President Trump officially declared the opioid crisis a public health emergency. Since then, though, the stats have only risen. Dr. Gold, I wonder if there's anything that we can do to lower those numbers going forward. Dr. Gold? I think he may have lost my audio, and that's understandable. It's a live television broadcast, after all, which is why we now invite you to join this conversation. All you got to do is pick up the phone, dial 877-731-6733, and we want to hear from you this evening. What questions do you have about any of the data that Dr. Gold just went over with us? Maybe you have a question about COVID, about RSV, or about this aggressive flu season. On the other side of this break, we're going to open up our phone lines to you, so stay with us. More Rural Health Matters right after this, including your questions. We want to hear from you tonight. Maybe you've always wanted to call, never actually done so. Let tonight be the night. We'll be right back with more Rural Health Matters after this. Welcome back to Rural Health Matters. I'm Christina Loren. We are glad that you're with us tonight. 877-731-6733 is the number to call and join our conversation. We would love to hear from you tonight. Joining us once again, world-renowned Dr. Jeffrey Gold, the Chancellor of the University of Nebraska Medical Center. And now we welcome Dr. Ann Anderson Berry, who serves as a professor of neonatology at the University of Nebraska Medical Center, and she is the executive director of the Child Health Research Institute. In addition to her medical degree, she has a PhD in medical nutrition, and she's been honored for her leadership in helping to expand healthcare services for mothers and babies across the great state of Nebraska. Dr. Anderson Berry, thank you for joining us once again. One of the biggest headlines in the news in recent weeks, as you know, Dr. Gold also talked about this a little bit in his opening segments, is the surge of RSV and flu in addition to COVID cases in adults and children. What are you seeing right now in the pediatric clinics and hospitals across Nebraska?
Yeah, we're busy. Unfortunately, this is a triple pandemic. It is impacting our youngest patients all the way through the pediatric population. We started very early for RSV in the late summer and early fall with a dramatic rise in RSV and a really potent, virulent strain of RSV. So we have a lot of infants, toddlers, and even some older kids that are hospitalized in the intensive care unit on ventilators. And just as RSV has plateaued in numbers, it's still going strong, but not rising as quickly. We've had a surge of influenza A. And in talking with my colleagues just today, we're seeing a lot of children outside of the toddler age, older children, school-aged kids in the intensive care unit, intubated on ventilators with influenza. And then we have a baseline rate of COVID infection. And some kids we're seeing positive for multiple viruses. So it's been profound. Waits in emergency rooms are incredibly long. And hospital beds can be scarce. This has complicated the situation by making some of the medications and other materials that we use to treat these kids very scarce. So it's been a stressful fall and early winter for us.
Oh, man. You know, it's tough. As the mother of a 3-year-old who is in daycare, I understand very clearly how serious this is. I do wonder, though, given the surge, what advice are you offering to parents to try to keep their children healthy and safe, especially when we rely on childcare and there's really not a lot you can do?
Absolutely. It's back to the basics. So, number one, wash your hands. Try to keep hygiene at a max. Little kids, it's hard. They put everything in their mouths. They touch everything. But if they're sick, it is important to keep them home to prevent the spread of these sometimes lethal diseases. And then for influenza and COVID, we have vaccines for children 6 months and up. For our highest risk neonates, we have RSV vaccines, and masks work. Masks are likely the reason that we had low RSV rates and low influenza seasons the last couple of years. And as we've relaxed our masking habits, this is the surge that we're dealing with now. So if you want to protect your kids, your family, if you have immunocompromised individuals in your family, it is safe, easy, and relatively inexpensive to mask up again.
Mask up again. You know what, especially as we consider traveling from the holidays, not a bad idea. We're going to talk to Dr. Gold more about that coming up as well, how we can best prepare ourselves before traveling, especially by air. But first, Brenda of Nevada is joining our conversation tonight. Thanks for joining us, Brenda. Go right ahead.
Yes, I'd like to ask Dr. Gold that, that I've read about studies being done that bats in China were the host of the coronaviruses that spread to humans. In your research, do you think this could be true?
Well, first of all, Brenda, thank you so much for calling. So there are a lot of different rumors, thoughts, suggestions about where these viruses originate. But we do know that there are bat populations that are hosts to certain types of viruses. We learned that with the Ebola virus disease that we saw in Western Africa, that we thought had to do with spread originally from bats into the food supply and then into humans. And so one of the theories, one of the more popular theories, is that the coronavirus was resident in a bat population, which then infected some mammals that became part of the food chain. And then one thing led to another. And as people consumed the meat from the wet markets, this was all ascribed to Wuhan City, of course, in China, central China. And that as a result of the bat to food chain to human transmission, we ended up with this incredible COVID pandemic. No one will ever know for 100% sure as to whether it was bats or for instance, we have been watching what's called zoonotic spread in mink populations. Interestingly, I just saw a study done here in Nebraska looking at the deer populations. You know, they in deer season, they harvest some of the lymph nodes from the deer, and they look at them for various diseases. This year, they happen to look at them for presence of SARS-CoV-2 cellular activity, and indeed, there was a presence in the deer population as well. And so we're seeing this combination of spread, of course, from human to human, but back and forth to the animal world as well. And so while there's no definite answer, the way you described it, from bats to the food chain and from the food chain to humans, seems to be the best accepted. It's not our research, it's what we read from other people who have studied this to the best they can.
Okay, thank you so much for that question, Brenda. We appreciate it. Bob from Indiana is our next caller. Thanks for joining us, Bob. Go right ahead.
Thank you. Thanks for taking my call, Doctor. I'm a 82-year-old male, both shots, 3 boosters, due for another booster. My cardiologist gave me an electro or some kind of a cardiogram, and said the walls on my chambers of the heart were thin, good chance of producing a blood clot. And I hear that the COVID shots will produce some blood clots. So I wonder, should I skip the rest of my boosters or go ahead and get them?
Well, again, thank you for calling, Bob. Great question. So the best advice for you is determined by your relationship with your cardiologist. And so you probably had an echocardiogram, I'm guessing, which is one of the best ways to non-invasively take high-quality images of your heart valves and of the chambers of your heart, measures chamber thickness and function of your heart muscle as well. The incidence of blood clotting associated with the COVID infection is extremely high, which is why people that get admitted to hospital are frequently put on blood thinners during the time that they're infected, because they get clotting phenomenon in their blood vessels, in their heart, in their brain, in their kidneys, etc. And frequently that's the cause of their demise when that happens. The incidence from the vaccines is extremely low. We did see some of that early on from the J&J vaccine, as you may remember, in middle-aged women. But with the current widely available Pfizer and Moderna vaccines, they're far less. However, depending upon what your particular echocardiogram shows and what your other risk factors are, and the fact that you've tolerated the other vaccines and boosters so well, I would let your cardiologist make that decision.
877-731-6733 is the number to call. Let's bring Dr. Anderson-Berry back into this conversation, because you and your team have conducted COVID-19 vaccination studies in pregnant and pediatric populations. Tell us what we've learned there in regard to safety.
Yes, we have, and we were part of the original Pfizer vaccine trial in pediatric patients. We are coming up on the final safety and efficacy visits for those research subjects, and what we have found is that in these patient populations, the COVID vaccine has been incredibly safe and with minimal, if any, reported side effects, particularly in the patients that we enrolled here in Omaha, and very effective. And so we are confident in being part of continued ongoing trials. We have a couple that are currently running that I'd love to share with your audience, and can recommend that parents can move forward with vaccination for their pediatric age children without reservation.
Okay. Dr. Gold, it's interesting that you brought up the blood clotting actually heightens with COVID more so than the vaccine by a great deal. I think there's so much misinformation out there regarding the vaccine and blood clotting. I just wonder if people didn't get their COVID tested, they didn't know if they had it, possibly they had it, had a blood clot from that, then got the vaccine and blamed the blood clot on the vaccine. I just wonder where that misinformation, where the origin comes from.
Well, there is not any question that there's a very small but definite incidence of clotting abnormalities that are associated with all vaccines. Because any time that you engage your immune system and rev up your immune system and produce antibodies against anything, whether it's a viral infection, a bacterial infection, a fungal infection, etc., whether it's the common cold, the incidence of revving up your clotting system occurs at the same time. But it's a question of magnitude and severity, meaning how frequently and how severe that occurs, as compared to what happens if you don't get the vaccine, where we know that the clotting abnormalities are severe and unfortunately not infrequently lethal. And so it's all about the balance, Christina. It's the, what is the risk of making one choice or making another? So somebody that has had a severe reaction to the vaccine, including clotting, that's somebody that probably should not get boosted. Somebody that's never had any reaction to the vaccines, has a normal clotting system, their risk is incredibly low, and they should go ahead and get vaccinated.
Okay, we're going to go back to Nevada, where Ron is joining our conversation tonight. Thanks for joining us, Ron. Go right ahead.
Yes. My question is the incidence of dizziness after COVID-19 booster shots. I had a booster shot in July. Since that, I've been to 7 different doctors trying to determine if there's some deterrent for this dizziness. I've been dizzy ever since. I still am, and this is we're up in the month of December now, and I have found no deterrent, no way to get away from the dizziness.
Well, Ron, again, thank you for calling in. I'm so sorry to hear about your dizziness. There are many, many different causes of dizziness, and some of them are due to, for instance, medication. Some of them are age-related. There are many well-known diseases that can affect your inner and middle ear. There are some neurologic diseases that cause dizziness as well. And of course, there are some very unusual types of stroke that can cause dizziness. Infections in the tissues around your brain can cause dizziness. There's a long laundry list. However, I would hope that a combination of the diagnostic testing as well as testing, imaging of your brain and areas surrounding your brain can be useful in trying to get to the root of some of your dizziness. I would never say it's impossible that there's a relationship to the vaccines, but it should be extremely, extremely low. I'd ask Dr. Anderson-Berry, her population is a lot younger than 80 years of age, but I wonder whether in your pediatric experience, Dr. Anderson-Berry, you've had any exposure to individuals who have been vaccinated who complain of any degree of dizziness or vertigo or related symptoms.
Thank you, Dr. Gold. We have not seen that as a primary report in the pediatric population with the COVID vaccine trial that we've conducted here. And in clinical practice, arm soreness is really the primary side effect of the COVID vaccine in the pediatric population. So it's relatively well tolerated. I would agree with your assessment that dizziness in the general population has so many different etiologies or reasons, and it can be very difficult to determine what exactly is causing that. So I sure hope your symptoms get better quickly.
Yeah, God bless you, Ron. Thanks for calling in tonight. We are going to California next to speak with Charles, who has a question. Thanks for joining us, Charles. Go right ahead.
Yes. Has there ever been any correlation or seen the spiking of this the viruses? Now, yesterday, Sunday, Texas had over 5,000 immigrants flood the border. California had 3. The largest number of immigrants, it got so bad that Texas just let them go. They couldn't handle it, and the buses were still being unloaded. That was on the news this morning. Now, if these people are flooding our country, see, that makes almost 12,000 to 15,000 people in one day. And they are unvaccinated, unmasked, and we do not know their health problems. How can the United States citizens ever fight something like this? We just can't continue, and they expect another 10,000 immigrants by Wednesday, again with the buses being bussed in from Mexico and South America. It's the largest number of immigrants ever seen on the border and been released in California and Texas on Sunday. And it's overwhelming. They just let them go. And here are kids, our adults, older people. They're just sitting here with this disease coming across the border with no checking it. There's no check. They can't even handle it. And the one tent, the tent was filled with 3,000, and they couldn't get any more in there to check, so they just turned the rest of them loose. And that was on the news. Why are we not comparing the spiking of this disease with number of immigrants coming across the border? Because a lot of this is not American citizens. They've done their vaccination and their mask and done a good job. I think we're just being invaded with a disease carried by these people.
Well, Charles, thank you again for calling. And I certainly agree with you that the challenges in our nation caused by the immigration patterns are very difficult. They're difficult for the individuals who are immigrating because many of them are coming from very austere environments, but they're also very difficult for the communities that are receiving them. Having said that, the United States government has got some very strict policies about screening, which I believe, could be wrong about this, but I believe includes testing for COVID specifically. It includes testing for other things as well, but it definitely includes testing for COVID. Whether that capacity has been exceeded by some of the recent immigration numbers, I certainly would not have the expertise to know. But if you look at the patterns on the U.S. maps that we have been sharing each week on this broadcast, you would think that Southern California and the southern border of Texas might have some of the highest spread rates if this was indeed being induced by individuals that were crossing the border either legally or illegally. And while we did have a lot of COVID in that part of the country over 18 to 24 months ago, we actually don't right now. Now, whether the maps will change in the future, it's something that we can watch. And indeed, I will see between now and the time we do a follow-up broadcast as to whether there's any correlation between the number of immigrants received in the United States in a day, in a week, or over a period of time, and map that, chart that out against COVID cases that we're seeing, particularly in the parts of our country that border Mexico. So thank you for calling, and thank you for that question.
And thank you, Dr. Gold, for doing that research. That's why we love this show. Dr. Gold works so hard to make sure that you have the most accurate data possible. It just reinforces the fact as well that we live in the greatest country in the world. That's why so many people are trying to get in. Part of the reason why is because we have great doctors, two of which will be joining us once again on the other side of this break. I want to give you that number one more time. It's 877-731-6733. I'm loving this conversation tonight, but you know what's missing? Your call. There's still time. Stay with us. More Rural Health Matters right after this. Welcome back to Rural Health Matters. Joining us once again, world-renowned Dr. Jeffrey Gold, the Chancellor of the University of Nebraska Medical Center. And our special guest tonight is Dr. Ann Anderson Berry, Professor of Neonatology at the University of Nebraska Medical Center. She's also the Executive Director of the Child Health Research Institute. We're going to go back to the phones. Our next caller is from Nebraska, where Robert joins us this evening. Thanks for joining us, Robert. Go right ahead.
Well, last March, I had the problem, my heart chamber went out of rhythm. And I'm 95 years old, and at the time I was, of course, 94, and I just wondered why, if that booster shot could have had any effect.
Well, thanks for calling, Robert, and it's great to hear from a fellow Nebraskan. You know, there's no way to know what causes your chambers to go out of rhythm, but as we get older, there's no question that there's a higher and higher risk of that. You know, at 94 or 95, you've obviously evaded a tremendous amount of reasons that people struggle with their health for decades and decades. And, you know, congratulations to you for taking care of yourself in so many different ways. That has created that longevity. And, of course, you need to thank your parents indirectly for the good genes that got you to 95 and hopefully many years. Almost certainly not related to vaccines. Could be related to a virus infection, but more commonly just related to stiffening of your heart valves and stiffening of your heart muscle that causes the chambers to dilate and swell. And as they swell and dilate a little bit, they tend to get out of rhythm. And that's typically what happens as we get older. Certainly beats the alternatives to getting older, however, I might add.
Thank you so much for that call. We appreciate you so much for calling in tonight. 877-731-6733 is the number to dial if you'd like to join our conversation. We'd love to hear from you. I want to go back to the opioid epidemic for a moment because it's had a severe impact on rural America. And Dr. Anderson Berry, I'm wondering about the effect on expecting mothers and their babies. What are you tracking there?
Well, thanks for that question, Christina. Unfortunately, we're not in a good situation here in the United States with opioid exposure and expecting moms. Just last week, we got data from the year 2020, and what we saw is the highest number of moms who were using or exposed to opioids during pregnancy, which therefore leads to the highest number of infants exposed during pregnancy. There are long-term and short-term repercussions of opioid exposure during pregnancy, including pretty severe withdrawal. We have babies in the hospital every day across the country who are suffering from withdrawal, having extended hospital stays. And some of our research here at UNMC, as part of a multi-center trial across the country, is looking at better ways to treat these infants with exposure to opioids. They can have irritability, poor feeding, dehydration, severe diarrhea, worst case scenario, seizures, and even death. So we have consortiums across the country, including our Nebraska Perinatal Quality Improvement Collaborative, that are looking at innovative ways to help moms understand the risks of using opioids while they're pregnant, and helping doctors to prescribe alternative therapies. And then, as Dr. Gold mentioned, with the One Pill Can Kill initiative, many times these aren't prescribed opioids, and everyone needs to understand the dangers of taking pills that they didn't procure from a hospital or a pharmacy.
Absolutely. It's so scary. I mean, it's hard to watch a newscast this day and age and not hear a story about a fentanyl overdose. Dr. Gold, looking out for our fellow rural Americans, we know that throughout the pandemic, drug use went up, isolation, depression went up, mental health challenges went up. How can we better safeguard our neighbors and get the word out more effectively? Because you don't hear a lot of awareness campaigns going on about this right now. A couple years ago, maybe, but I haven't heard a lot lately.
Well, this is where the opportunity to talk about it on broadcasts such as this, Christina, are so important. And that's one of the reasons that I chose to focus on it this evening, particularly as we're getting into the holiday season. As you know, our audience probably knows, if you look at the incidence of severe depression, levels of anxiety and stress, the holidays unfortunately tend to bring that out. More people are gathering closely and traveling, and those things also bring out anxiety and stress. And unfortunately associated with that is the use of legal and illegal medications and drugs. And the more we talk about it, frankly, the better. We need to destigmatize the conversation, which means that we need to be open with our friends and our family, or with our kiddos, with our parents as well. And, I would say to our audience tonight, this would be an opportunity over the dinner table, perhaps in the next several weeks, to say that Rural Health Matters focused on this, the One Pill Can Kill campaign. Did you know about that? Now, no one's going to sit up at the dinner table and say, by the way, that could be me. But what they will do is share that information with other people that they may know who are at risk. And so I do think the more we talk about it, the more we remove the stigma associated with these conversations, the higher the chances are that we can reduce the incidence. And more importantly, get individuals who may be addicted to opioids and other drugs into help. Right now, there is excellent medication and therapy for these individuals. We have a program here in Nebraska that is absolutely amazing, that uses a number of different medications and a number of different types of therapies to help people with addiction. I'm sure every state has similar programs, but people have to be willing to raise their hand and say, I need help, or a loved one needs to come forward.
Yeah, in the Midwest, many police stations will actually test drugs for you, which is interesting as well. Mm-hmm. So that's something that people can also look into or let their loved ones know about. Speaking of Christmas time, I'm certainly celebrating. I'm sure many of our viewers are as well. This is the closest to normal we've been at Christmas time in 3 years. Many of us will be traveling, but Dr. Gold, you pointed out 68% increase in wastewater viral particle counts in addition to RSV cases and the seasonal flu. As many of us do prepare to sit around the dining room table, have these discussions with our family members, how should we go about protecting ourselves as we get from here to there and back this year?
You know, it's to me, and I'll ask Dr. Anderson-Berry in a minute, but to me it's just common sense. It's the same things that we've been talking about. You know, if you're ill, stay home. If you've been exposed to somebody recently that's got the flu, has RSV, COVID, or just a common cold, get tested. We have very good tests for all of those illnesses, and we have, you know, for 2 out of 3 of them, COVID and for the flu, we have good oral medication that will reduce the severity of the disease or prevent symptoms if you take it early enough. And that, of course, would be Paxlovid for COVID, and it would be Tamiflu for influenza. And both seem to be working quite well, even in spite of these super spreading variants that we're seeing. There's still plenty of time to get either immunized or to get your booster shot between now and the holidays, which are around the corner. But, you know, a 10 to 14-day window from when you get your boost or when you get your vaccine dose will protect you, and in so doing will protect others. And then, you know, lastly, I would say, you know, as Dr. Anderson-Berry said so accurately, wash your hands, stay away from people that look ill. If you're in a large public setting, you know, I still wear my mask. You know, when I'm walking through an airport, getting on a plane, you know, I did do some travel over the last weekend, and every flight attendant was wearing a mask, and interestingly, gloves for the flights that I took. And, you know, that's a change because, you know, when I would fly in August to a meeting or to see family or whatever, I would say very few people on board and very few of the flight attendants were masked up or, you know, protecting themselves and protecting others. But I think the numbers that we're seeing across the country have really made people aware. You know, at the end of the day, they're going to want to spend time with their family and friends and loved ones over the holidays. And the last thing they're going to want to do is have COVID or the flu, you know, on Christmas Eve. Just not going to be any fun for them or for anybody else. And so this is a time to take some precautions. But, you know, I'd ask Dr. Anderson-Berry, is there anything that we need to be aware of for our kiddos that might be different?
You know, again, it's a matter of what's your developmental stage and age for your child. For our babies, we aren't recommending masking. That's not safe for them. As you get into the toddler and preschool age, many kids will wear a mask and have been wearing masks over the last 6 to 12 months at school and in other crowded situations. It's not unreasonable. And I would agree with your statement. I want to see my friends. I want to see my family. I don't particularly enjoy being sick. And so it's a very simple, cheap, and easy way to minimize the risk.
That's right. Who cares if people on a plane see you, strangers, for a few hours when you get to enjoy your time with your family, knowing that you didn't bring anything but a Christmas gift with you to that household. I want to thank you both so much for joining us. Dr. Gold, we've got a few moments left. Do you have any final thoughts for us tonight?
Just to thank Dr. Anderson-Berry for all that she does. You know, we didn't talk much about neonatology and the trends across the country, but there's still a lot of opportunity, particularly in rural America, for improving care of our neonates and our pregnant moms, particularly with high-risk pregnancies. So, Dr. Anderson-Berry, thank you for all that you do.
Yeah, thank you for looking out for our youngest Americans. God bless you both for looking out for rural America. We'll see you right here next week live for Rural Health Matters.